We're very delighted that Kelly has joined us from Dartmouth in the US, and Kelly has as well a huge amount of practical experience. So we were very much looking in our search for who to ask to join our external advisory group and who to ask to come and speak today and who has really good messaging to give to you and to everybody online. And Kelly very much hit all the metrics that we had in relation to this. So one of our key things was we wanted pracademics, as they're called, people who, maybe come from an academic background or who have been engaged in research and publications, but who have been involved in practical initiatives on the ground, where they live, in their communities, in other communities, and who integrate that into their day-to-day work. And Kelly has some fantastic stories to tell us about the work that she has been engaged in and the impact that it has on people in enduring mental illness in her area. So Kelly, I'm going to pass over to you.
Thank you so much, and I'm really excited to be here today and get to share our work with you, and thank you to Tara and Catherine and Sarah for being so welcoming, and it's just really exciting to be here with you today. And I also want to mention in my introduction that I am a co-director of a new implementation science center at Dartmouth, and the field of implementation science is all about how do we address the research to practice gap across health conditions or health issues. And so all of our work is taking evidence and working with people in real world health settings to translate that evidence. And today I'm going to be sharing a study with you that was funded by our National Institutes of Health. It was my first large trial focused on supporting young adults with enduring mental illness and supporting their health. So the next slide, please. So, and all the wonderful experience and expertise, it's all great. It's going to build a nice foundation for what I'm going to be talking about too. And we know that studies that have shown that lifestyle programs that provide support for physical activity, maybe not nutrition, but certainly healthier diets, can improve the health of people with enduring mental illness through weight loss and improving fitness, even among people taking antipsychotic medications. So numerous studies have shown that people can still benefit from these programs. And in the US, these programs are becoming widely implemented in our community mental health system, which is our publicly funded mental health system. And so we're moving to the point from having these evidence-based interventions to actually working to get them implemented, and there's a method and systematic way of thinking about even doing that as a science, the implementation work. But unfortunately, if you look at these studies of lifestyle interventions for people with enduring mental illness or serious mental illness, you'll see that the average age of most people who enroll in those studies is age 50. So if we're interested in addressing health and preventing these long-term physical health problems that this group has, we have to think about how do we intervene earlier when people are younger and help them provide opportunities to these types of interventions. So next slide. And so fortunately, there is some literature from the general population where researchers have asked young people, what do you want from a lifestyle or weight loss intervention? And so these are people who are in the general population, maybe have a mental illness, maybe don't. And people have taught, young people have taught, and young people has been defined between the ages of 18 to 25 or 18 to 35 or 18 to 40 in some instances. But when young people talk about weight loss or lifestyle interventions, they talk about maybe not weight loss is the central motivation, even though that may be of interest to them, but really also thinking about self-improvement and fitness, like, and things like wanting a briefer, more low intensity, maybe a hybrid program where they're going to some sessions in person and maybe part of it online, and really wanting to make sure these programs emphasize their autonomy and their choice. So it's about what they want to do. They're getting support or coaching, but how do you help support that? And then when researchers have compared the preferences of younger people and older people who are have been through a weight loss experience, the younger people talk about interest in their appearance and social motivations for weight loss. That health issues are just they're not experiencing necessarily those health issues yet, so they're far in the future. They're more interested in what you would imagine a young person's interested in. And then small qualitative studies have asked people who have first episode psychosis what they're interested in, and they talk about the link between, understanding there's a link between their physical health and their mental health. They want to experience improved self-esteem through losing weight. Maybe they've gained weight being on some of these medications and they're aware of it, and they want to lose weight to feel better. And so in the next slide, I'll show you a picture of our team. So this is our team that was funded by the National Institutes of Health that included 4 of our community mental health centers and some young people who were experiencing enduring mental illness and a number of different investigators. And so we took on this challenge of how do you design a lifestyle intervention for people, young people with enduring mental illness that would be appealing to them and they might benefit from. So in the next slide, what we did in our trial, which we call the Fit Forward trial, is recruited 150 young adults from 4 community mental health centers who had a body mass index of 25 or higher, so they were considered overweight, and some had obesity, and we randomized them to either a program that was group-based. So some of the things that were mentioned earlier, the idea that young people might want to be with other young people who are going through the similar experience and get a chance to get together and focus on their weight loss and fitness goals. And that was enhanced with popular technologies that I'll tell you about in a minute. And we compared that group-based intervention to something that was one-on-one coaching, and it was almost entirely done remotely. Okay, next slide. So the intervention that we actually hypothesized was going to have a stronger effect was our Peer Fit lifestyle intervention. So this was group-based. Participants met for twice-weekly sessions led by a personal fitness trainer, and they were done in their community mental health centers, place where they were getting their mental health services care. And those sessions were enhanced by a Fitbit, so a wearable technology for self-monitoring. So we didn't collect the data from the Fitbit. It wasn't for us. It was for them to use a way to self-track and look at their fitness or they're increasing their steps, however they wanted to use it. And then we had a private Facebook group that brought the group that was moderated by the coach so participants can engage and enjoy with each other outside of the group sessions. And then that was enhanced with supported text messages from their coach. So on the next slide, a little bit more about PeerFit. It was informed by principles from our diabetes prevention program, guided by social learning theory, where the idea is you're learning from other people in your group, and then you get a chance to experience some health behavior change in a supported setting with your coach, and try it, see how it goes, try it again, try something different. And the peer-to-peer support was with each other. So the peers were other people in your group who were going through this health behavior change experience. So in the next slide, so this was really important. When we thought about digital health, there are lots of ways you could do this. You could use an app that's an app. You could develop an app. You could design something new for people who are in your study. And we just wanted to use popular technology. And we thought, well, why not use the things that young people at that time were using in their daily life and capitalize on those. So instead of trying to integrate something new that people have to incorporate in their daily life, use the technology they're already doing and see how we could leverage that to support health behavior change. And so participants had the wearable device, the Fitbit, and then they received text message reminders from their coach and this private Facebook group. So on the next page, I'm just going to show you an example of what a text message would look like. And so the coaches gave them participants 3 to 5 times per week. In PeerFit, they were for reminders and encouragement and motivation. And so they checked in. Mainly it was reminders, reminders about class, that the class would meet. People just appreciated, or I think the reminder was also an encouragement that we're meeting this week. But also they interacted with them around their physical activity and encouraged them to be more active. And in the next slide, so that was our experimental condition, the one that we thought was going to be most effective. And so we compared that condition to something that wasn't group-based and something that was remote, where people weren't coming together, and that was our BEAT lifestyle intervention. So that was basic education supported by activity tracking. And so BEAT involved coming once in person to meet your coach, to have an orientation session. The BEAT coach would tell you about what was going to happen in BEAT. You get face-to-face time, but every other meeting after that was remote. So it was a once monthly telephone coaching session, and we wrote a curriculum for the coaches to use to walk participants through those coaching sessions. And then it was the text messaging. And the text messaging in BEAT had more of it wasn't just physical activity, it had an emphasis on healthier eating, not necessarily nutrition. Because the BEAT was delivered by non-clinical people at the mental health. It was delivered by case managers. So people who were used to working also with young people in the rest of their life, not necessarily focused on just their mental health symptoms. So in the next slide, a little bit more about BEAT. So when we talk about healthier eating, some of the concepts that we used in BEAT were pretty simple, thinking about, but things that people still appreciated support for. So thinking about how do you increase eating fruits and vegetables, how do you reduce sugar-sweetened beverages, thinking about your junk food intake, and then really focused on substitution, so eating more of this and less of that, including increasing lean proteins people were eating. So we took a broad public health approach because we wanted case managers to feel comfortable talking about healthy eating without feeling like they needed nutrition expertise, which just isn't scalable, at least at this time in the settings that we're working in. And then daily physical activity of any kind. So being active, however suits you. In the next slide, and this is some data where the most important thing for us to understand in this slide is it's asking, well, did participants experience a significant change over time in terms of significant weight loss and significant improvements in fitness? And the answer is yes. Over time, it's measured at 6 months and measured at 12 months. So in the next slide, one of the outcomes that we were really excited about, especially because this was a secondary focus, the NIH wouldn't fund us to look at weight gain prevention. They wanted us to look at weight loss, but we measured it anyway, even when we weren't funded to do it, and it was very exciting, this finding that over 50% of participants, so you can see at 6 and 12 months in both groups, didn't gain any weight. So they were either at or below their baseline weight, which is so important for young people whether you have an enduring mental illness or not, because young adulthood is actually the time in our lives where we gain, on average, the most weight we'll ever gain because of all types of things. You're living away from home, maybe you're preparing your own meals for the first time, and you're not, you're eating what you want, you're at college, there's all types of reasons why, or you're taking an antipsychotic medication that may increase your weight gain. So, and then here's some quotes from our participants, and I took these are quotes. I wanted to show you both PeerFit and BEAT quotes that represent people's experiences. And you can see in the blue, the dark blue, those are BEAT, quotes from BEAT participants. And one participant said, because I have so many appointments and I have so much daily stuff, plus a son, I didn't have time to go to groups and all that. So doing this, she was in the remote coaching group, it was much easier where I knew I'd be able to participate and still text and do all that and still take care of my son and then still be able to talk to you guys. And another BEAT participant said it was really easy. I liked having the Fitbit and keeping track of the steps and getting the most motivational text messages. It really didn't interfere too much with my normal life, which was nice. It was beneficial because it made me more aware of what I was doing every day as far as activity. And then when we talked to some participants who were in the PeerFit group, and these were both people who felt like they benefited from that group-based intervention. One participant said, since I put all the weight on due to problems that I've had in my life after grieving the loss of my parent, my goal was to lose weight, and this is the only thing that worked, was consistently going to a class and participating and being part of that community. They lost about 22 pounds in the program. And another participant said it's not just fit and getting healthy, it's socializing, getting to know people in the same boat, and just very supportive and non-judgmental type of environment. You're getting more than just exercise and fitness out of it. So in the next slide, but okay, it's like, well, there was no difference. The other thing I should mention is there was significant change over time, but no difference between the group. So people in both groups benefited. But when you look at, well, okay, but did they attend? What was attendance like? You'll see it was not great in the group-based, it just wasn't great in the group-based intervention. The mean was around 6 out of 24 sessions attended, 5 out of 24. And then we looked at, okay, well, we understand it can be, we heard, it's just very challenging for people to consistently come to a group session in the centers where we worked. And we said, well, what percent attended at least the first one? You know, is it they came to the first one and then dropped off? And you'll see in the peer-fit group-based, it was about 70% attended a lifestyle session, 75% attended exercise. But when you compare that to the BEAT, which was remote coaching, 97%, almost all of them came to at least the first session, and then they attended 4 out of 6 of the lifestyle coaching sessions. So it gives us some insight into session attendance, and session attendance was correlated with weight loss in the BEAT intervention, not in peer fit. So you also want to ask, okay, they're coming, but does that correlate with the outcomes you're looking at? So in the next slide, to summarize these results, the peer group intervention we thought would be more superior than the BEAT, which was pretty light touch. It was not in achieving clinically significant weight loss or fitness. Both interventions significantly improved outcomes, and importantly, weight gain was prevented in over half of participants over a 1-year period. And engagement was a challenge for the in-person group intervention, but it was not for the mobile health coaching. And then the next slide, some of the things we learned about implementation that are really important for the next phase of carrying this type of work together was important to address in our community mental health centers, the leadership and staff perceptions about things like weight loss. So we heard even from psychiatrist team meetings that they would say, well, our participants aren't interested in weight loss. That's, young adults they don't care about. That's not something I want to talk about or think about. That there could be a negative impact. So another concern was, look, if you introduce this health coaching on top of their mental health care, they just might get really unstable and have problems. And we just don't want to introduce anything new while they're receiving mental health care, which we didn't have, I think, any people in our study with adverse mental health problems that were triggered through having these coaching experience. And that there's young people, they don't have access to popular technology. And we'd say, well, have you asked them? Have you talked to them about what they're using? Have you talked about them if they're using smartphones or if they're online? How do you know they don't have access? And so I think those are some things to think about. And the data supports now that shows that lots of people who are living with enduring mental illness have access to technology and use it regularly. But we still need to think about, also need to design interventions for integrated with mental health and health services. So this was a study, it was layered on top of what routine care is provided, and so we are thinking of that next step of how do you get something that's, especially now we have some evidence behind it, actually really integrated and paid for and into the workflow of the providers we work with. And one way to do that might be coupling it with their psychiatric medication management. So maybe BEAT is part of offered as part of your medication management treatment. Maybe it's integrated into primary care services, so their primary physical health care services. They're often co-located in our community mental health center through grants in the US, so maybe that's an avenue. And then also back to this thinking about the clinical skills. You're going to take time away from a psychologist to do this, or could you use a case manager or someone else with non-clinical skills that can be trained in providing support for physical activity and healthier eating or nutrition? Okay, so key takeaways were thinking about these light touch, remote coaching interventions that could be delivered by non-clinical staff and thinking about their can have impact. and learning that participants really like flexibility and receiving support on their own terms and at their convenience, so they can ignore a text message. No one was expecting them to reply, if at all, but especially not in that moment. They can reply when they're ready, if they want, and thinking about how it works for them. And then the nutritional messaging that focus on maybe substitutions, so big picture. Unless you have the ability to provide really one-on-one, high-level nutritional counseling, that's one avenue, but we don't, and so we have to think about these larger messages that will help people make changes that are going to improve their health. And then finally, the researcher community partners. So we're always partnered. All the work we do is partnered. It's never alone as a researcher. We have to work together, especially to think about some of the challenges that I mentioned from the beginning, and how do you take those on before you try to implement a new service, and identify new opportunities for successfully implementing programs like this one. Thank you.